Have you heard the term, speaking of using age? I mean, I know age has the use of age has increased as a criterion for determining who gets care under these conditions for various reasons, which you can articulate further. But somebody, Daniel Sulmazy, he's a physician and an ethicist that I've come to know over the years. He was at Chicago. He's now at Georgetown, I believe. But he used the term in a recent lecture called chronometric rationing. I'd never heard the term chronometric, but it's kind of a fancy term for using age, right, as a measurement for.
So I mean, that's a fascinating thing, even just between, well, I think all three of our hospitals that we respectively work in, assuming that Zack's got beautifully well-tanned 6-year-olds that are still jogging every day, it's somewhere in the middle. And then Owen's hospitals, essentially the challenge is that they are biologically 20 years older because of deprivation. So and you see that with their index conditions. So things like ischemic gut, that age of presentation is roughly, and is about 10 to 15 years younger than the population you see within even my hospital or hospitals that serve people that are much less deprived. So therefore, age can't just be the only thing. That kind of chronometric restriction or allocation of care it's only one. That's why there's complexity, and it can't just purely be age. You can be
right. So with respect to presentation, how do you sort through that then with that kind of differential? Right?
I think it's context, and I think we'll get into that in the chat, but it's context, availability of resource, and what can be offered. And clearly Zack can go hard with ECMO if he chooses to, whereas we don't have that availability locally. So to put somebody on VA ECMO they have to, it's pretty brutal to do quickly, because we need to bring people in from another hospital and all the rest of it. So that means that unless it's a 16-year-old that's taken a vast amount of beta blocker, we're probably not going to go hard on that, and accept that the resources that we have available are the ones that we can consider, whereas the more esoteric, high-end ones such as ECMO, we are limited to provide unless there's a compelling, an overwhelmingly compelling reason to press that big red button and spend £250,000 on putting somebody onto ECMO. Whereas Zack will be able to build them back and get the £250,000 back.
Put them back to work.
Yeah.
We'll make you get that ECMO cost down. I think these are really good points. I mean, yeah, you can't just use age alone. In California, we've actually had, several restrictions of even using age as a criteria at all. That would be thought of as discriminatory. So you cited that we've been increasing the use of age. Well, in some ways, we've actually kind of decreased our formality use of age, simply because is that really something that you can put it in writing? I mean, of course, you're going to use all these things in combination when you're making your decisions, but to say that at this age we are not going to do it, that's definitely problematic.
Yeah, and legally we're not covered. There was a big discussion with our medical association, and I think there was the same in the States. I think I remember reading the same from you guys about the AMA looking at, will they indemnify if you make decisions due to lack or scarcity of resource? Can people chase after you and still sue you? And we never really got to that point of the PMA or the government indemnifying us, but it came very close, and our board certainly sent an email saying, we will cover you if you have to make tricky decisions. But ultimately, our escalation decisions now are 3 consultants making that decision. So it's not just, usually it'd be 1, maybe 2 people making an ITU level escalation. Now it's always 3.
Wow, and that's recent, the addition of a third?
That's COVID driven. That's very much a kind of COVID driven. We've got an MDT every day, which I don't think you guys are doing at the Royal Owen, but we do a multidisciplinary team meeting every day to decide escalation of those that we consider for level 2 care, which would be non-invasive ventilation, and also whether or not we consider them for level 3, i.e. intubation ventilation. And that's a function of the legality and the potential around about challenging that from family.
Yeah. Did
Wait,
you see
David, let
the?
me just make sure I understand what you just said.
Yeah.
So every day you have a team of 3 physicians that decides whether someone is going to go on BiPAP or whether they're going to be intubated or whether they're going to be withheld from that treatment.
Everybody that's on our blue pathway, so everybody that comes in that's COVID, that's got an oxygen requirement, goes onto our blue pathway, and they all get reviewed on a daily basis to say, is this somebody we would take to level 2 care or level 3? So you almost have a stamp to say, yeah, this is, we think they're a goer, and if they need it, we'll do it, as opposed to, no, actually their ceiling of care or their escalation decision is going to be such that they will not be escalated to ventilation.
So then tell me about what patient population you're looking at. Are you saying like the people, and I know it's hard for us to make equivalencies here, but are you talking about deciding ventilator restriction for people that should, or that are like in their 90s, or are you talking about people like that are in their 50s?
Across the board. So everybody, it's not ventilator restriction. I think it's around about appropriateness of escalation. And I know there's a nuance in that language, but ultimately it's a consideration of who would benefit and can we provide that care in a safe fashion given the resources that are available. And there's clearly multiple factors you take in terms of the analysis, consideration of that patient, age, comorbidities, frailty, all the kind of features that are well worn and discussed, but ultimately they're all taken in. You do a multidisciplinary meeting where you review their case notes, review what their current status is, and make a decision about, would this person be for escalation?
And so how many people would you say, or how many ventilators are in use at your hospital? What percentage of the ventilators that you have?
So it's nothing like you guys in terms of the States. So we have 4 ITUs potentially that are flexed to ventilate at the moment, where typically we would have, I think, 25 beds, whereas now we can flex up to somewhere close to 40. I'd have to check those numbers. But level 2 beds, that would be people on non-invasive ventilation, which needs essentially 1 to 2 nursing. And there's still a consideration of who is appropriate for escalation to that as well.
So I'm sorry, I got lost in a couple of those terms. Did you say you have 4 ventilators or 40 ventilators?
40.
40 ventilators. And what percentage of those are getting used at any given time?
So we were full at a number of points and transferring out to other hospitals or taking in from other hospitals. So at peak of both wave 1 and 3, we were ventilating on all those beds.
Wow. Yeah, that's rough.
That's what you've seen across Europe. I think that's the fascinating thing, is that ultimately this has been it's been a pandemic, but it's a worldwide challenge around about scarcity of resource. How do you allocate those resources? I mean, we've seen that played out a number of times: ventilators, drugs, now vaccines, as how do we provide these equitably? And the WHO has obviously been fairly forthright in terms of vaccines about not just being, well, that AZ, Oxford is made in Britain, so therefore we'll look after ourselves and then we'll deal with the rest of the world under kind of a set of sliding priorities.
Yeah, we got in trouble for buying all of remdesivir, or 90% of it, right, back in June, and then Canada's now in hot water for buying from the COVAX supply, right? When the WHO is saying this is for low to middle income countries, and you know what do you need this for right now, right? So we're definitely seeing global trends in hoarding and taking from richer countries, right? So it's a major problem.
Yeah, and it's how do you share them out and the costs of doing that. And ultimately, let's face it, for these drug companies, they were subsidized to do the drug discovery piece by the first world countries, the UK, EU, that got them preferential rates. But this is going to be a continued commercial success for them, probably for the next 5 to 10 years, if not longer. So therefore, it's how do you make that available to the whole world, potentially, understanding the mutations, and how do you manage those variants to ultimately control spread? Because actually having reservoir of disease in Brazil, India, as we've demonstrated with China right back at the start, will spread again. So therefore you have to be equitable to try and maintain a degree of control.
Yeah, and back to something you noted before. Did you see the BBC report, or it was basically a plea from medics that they not get prosecuted for the decision making they had during COVID, right? Under conditions of rationing and distress. Do you see that piece? Yeah.
Yeah, so and that's been played out a lot, and I suppose that's what Zack and I were discussing around about the kind of 3-line width in terms of decision making process. It's documented to say that we're either going to escalate your care or you're not suitable for escalation, and therefore an understanding of having multiple people involved in that decision rather than it being one person at 4 o'clock in the morning making that can be challenged. It's actually, this is a body of peers, which is the old legal challenge within the UK. Is this what a normally physician would do in normal circumstances, and that passes that. It's called the Hunter and Hanley test, I think, from memory, and that's about an understanding of this is what's done, then that's acceptable.
Yeah, no, that's great. Thank you. And thanks for offering that in the notes here. You sent the National Institute for Health and Care Excellence guidelines for rapid care, 27th of March. Hey, my birthday, 2020. So yeah, thanks for sharing that. I wanted to actually, so if we think for a minute, we can keep ranging on this. This is fantastic. Keeping in mind that my audience right now is our master's degree students with an ethics course, who might learn from how you all have made and continue to make decisions. I think it's something really helpful for them to understand in the context of ethics, right? And I'm going to use, David, the text you gave me kindly back in Switzerland in 2019, How Doctors Think by Catherine Montgomery. And she says this in relation to what we're talking about in chapter 7. She says, clinical judgment is not a skill separable from a well-stocked fund of scientific and practical information. To provide good care to their patients, physicians must know human biology, both normal and pathological. Yet if science were all that physicians needed, patients would be able to consult a user-friendly computer program and never need to see a doctor at all. Sometimes it seems as if medicine is already halfway there, especially when expert panels create algorithms that map successive decision points in the patient's diagnosis or treatment, right? And you just shared a decision tree with us, right? In this context. So if you can think back to a student at the master's degree level who's thinking about trying to learn how doctors think, trying to think about ethical principles and learning from you all, right? How do you now integrate, because you're now at a much later stage, when was this written? This was written a number of years ago, where you're integrating AI and all kinds of other information in your diagnostics and your decision-making. How do you tie that all together with now 3 people consulting, all the information you have, the basic science you must know? Are you consistently, I know you're consistently updating your scientific understanding. Do you have basically ethical principles you both have used, or all 3 of you have used in the past, that continue to inform that? Or do you also do similar kind of ongoing educational work to update how you're thinking about ethics in this context?
So I'll go first. I suppose at medical school we are taught about the basic ethical principles of autonomy, beneficence, non-maleficence, and justice, and that, I suppose, is the cornerstone of what we do in terms of decision making. And I think, as that book talks about, it is decision making is a confluence of both a skill and a science, or an art and a science, and an understanding of how do you integrate the mechanistic basic science understanding with what you've gleaned from the patient and what you ultimately think will be the clinical course in the context of COVID and escalation of care, which is what we're broadly talking about. And that's where often the challenge lies. And if you think about artificial intelligence or augmented insight, which is often the way we think about it, is giving you simplistically a probability of an outcome with a confidence interval for which that should support. And that's the context that we are certainly integrating into our clinical pathways, is in terms of being able to provide clinical decision support. So it's another data point to be thought of, considered, and ultimately integrated into your decision making. And if that's a probability of survival with a confidence interval, that's actually the same at patient level as when you well read from the journals and you're looking at what their survival curve would look like, and you're applying a Kaplan-Meier to that population with an understanding that the beautifully formed RCT, randomized control trial, doesn't actually necessarily reflect your population. And therefore you have to integrate the knowledge you've gleaned from that patient. It doesn't necessarily represent that beautiful cohort of patients with only 2 comorbidities, all at the age of 25, who live in San Diego.
Yeah, no, and that's a good point of hers that she makes that I think you're getting to too. She says, of course, you're at the early stages of training, you're encouraged to think of the kind of certainty you can gain from the knowledge that you're amassing during basic science courses and all your science education. And yet, what you face, and she says this is what's so important about practice, is the genius that you get involved in is the ongoing genius of the practitioner who has to deal with uncertainty at all times, right? So you might have those studies of RCTs and populations that apply, we think, generally, but at the end of the day, you're making a judgment about a very particular case, and so your practitioner's sensibilities, almost like your spidey sense, is capable of making a judgment under those conditions that is able to adjust on the fly, ad hoc to those variables that are always shifting. So yeah, no, I appreciate the comment about integrating.
I think that's the fascinating thing about all decision-making pathways is they are the substrate you work with. Ultimately, that's the baseline performance that you should, as a junior doctor, apply to, and then you hope that people will break glass and move within that corridor of acceptability, and their performance will be greater. But that level of the pathway, the guideline, is the point where you should adhere to, with an understanding when you choose not to, you are able to justify, explain, or at least be able to point to it and say, I've considered this, but I'm going to do this. And I think that's a critical piece around, I suppose, all decision making. But I'm aware you've got 3 emergency physicians on this call who all essentially embrace uncertainty. They don't come with a beautifully packaged patient that you've got 6 hours to read their notes, do some more tests before they come up to clinic. And therefore, our management of uncertainty and our ability to embrace it looks very different than other medical practitioners, even our intensive care colleagues who have hopefully at least a degree of packaging and information that we've performed in the intervening time that we've met the patient before we make a decision that they potentially should be escalated for consideration of ventilation or another higher level of care. Zack, what's your thoughts?
Yeah, I totally agree with the concept of you have limited information. I really like what you said there about, trying to incorporate whatever knowledge you have, whatever algorithms, whatever data you have, but that I think ultimately it does come down. And I like also what you mentioned at the beginning about these kind of pillars of ethics, but it is so interesting. And I think when you start talking to students of bioethics, it's so interesting how your own personal ethics play into all of this. They play into all your decision making, not just for limitations of care, but so much of emergency medicine is just kind of how you view the world. And then when we start talking about limitations of care, the ethics they're never perfect. They're never pretty. It is a judgment call. And so I think a lot of people talk about ethics, but what we do in the actual emergency room or in the ICU or even on the wards is ethics with a high degree of practicality. It's making real decisions that have real impacts on people in the moment with limited information. And
Zack, you said you're making some of the decisions, or did you have to write up some of the protocol that's applied in your ED? Is that correct? Or how did that work in terms of your involvement in preparedness for COVID-19?
Yeah, so I have been involved with quite a few of our policies, and again, these are hard to write definitive policies, as David already mentioned. I think that, and this is kind of plays into one of the things I just find interesting from hearing from David, is that you hear how bad California has been with COVID. And yet I think that David's probably making much more critical, well, much more difficult decisions than we're making as far as even restriction of ventilation. We have not had a lot of problems with that in San Diego. We also have a big problem north of us in Los Angeles, which has led us to accept quite a few patients from outside. But most of this is actually decision-making over VV ECMO as opposed to ventilation, which is, I think, a much more questionable decision. Like, ventilation does have benefit. Like, we do know that could improve someone's outcome. VV ECMO, I mean, you could argue that there's not really great data that says that this is helpful, and that the resource allocation to do so is substantial. So those decisions, I think, are I think very fascinating, and they're at the forefront of my mind. But some places, if you're talking about ventilation, is a whole nother strategy. And then when you even talk about maybe farther, like very undeveloped countries, where they're talking about, you know, even supplying oxygen, it just becomes a much more difficult decision. Maybe it's the same decision, but it's just a different interplay of how effective the therapy is for improving outcomes.
I suppose if you think about our colleagues that work in Africa, I think it's the same decision-making process. It's just which bit of resource is scarce.
Yeah.
Is it antibiotics? Is it oxygen? Is it a bed? Is it ventilation? I think, to be clear, we've been very lucky. We've skated through without having to say no to anybody that we'd want to ventilate. But clearly in other countries, that's not been the option. But we've had to think really hard about those protocols and pathways. And as you said, it's that balancing of pragmatic medicine with paternalism and having good conversations with family. And I think that perception of quality of life plays into that. And that's our perception as clinicians versus the family members as well. And that can work both ways when you say, would you want to go on a ventilator if you're very unwell? As a theoretical question at 2:00 in the afternoon in 2018 versus in March of 2019 when everything started to get much more restricted. So therefore, I think that question of perception plays into whether or not you think this person's quality of life is such that giving them a shot on a ventilator when their outcomes are likely to be poor, because you've got all the data there, their Apache score is high, they've already got an FI requirement of 1, and they're already acidotic, all those kind of clinical features, but ultimately, does that person substrate, biological or otherwise, be such that you should go hard? And that's also driven by what the patient and the family ultimately want as well.
Mm.
Oh, and chime in here. What are your thoughts?
Just thinking how clever Dave Lowe is. I mean, all we need is clever.
That's what I'm thinking.
it's just, I don't know that I can contribute in this scientific level. I'm a much simpler brain. I get, well, a couple of things. I guess it's an evolving thing with COVID. You know, for example, I know that in the first wave, the mortality rate of people ventilated was something like 35%. Dave, you can probably tell me something different now, but currently in our hospital, it's up to 65 or 70% mortality for people being put on ventilators. And that's even though they've been decreasing the age at which they ventilate. So you'd think that would reduce the mortality rate, but it's actually gone up quite significantly. So it will evolve even in the course of a disease, you know, that will factor into decisions on who and who are the appropriate people to get ventilated when you know that the mortality rate is now so much higher. That was one thing. And then another thing I was thinking about was treatment escalation plans. I don't know if that's a thing where you guys are, maybe it's a completely different topic. And I don't know if it's been heightened a little bit by COVID, but we've started to think sensibly about all people's escalation of care. Certainly in our hospital, we've become quite, it's become a new fashionable thing. Dave, I don't know if treatment escalation plans have reached your hospital yet, but you know, we're being encouraged. We've probably evolved into a service where we just do things because we can. You know, we throw everything at people, and I think I've certainly seen in the last year or two, we're starting to think very sensibly about what sort of care we give all people. So this isn't COVID now, this is separate. So we've introduced these treatment escalation plans for resuscitation, patients in the resuscitation room. And it's a 1 page or 2 page document. It's just trying to give everyone a sensible ceiling of care. Now, it's fluid, it can be reassessed, it can be reviewed, probably in not MDT type scenarios, but I think the physicians on the ward will review it on a daily basis. But it just sets the bar for someone as they progress to a ward. It informs the staff who are taking over their care. This is kind of the trajectory or the plan for this patient. And it will be things like, the highest level will be intensive care. Next will be maybe some non-invasive ventilation. Next tier, it's just 4 tiers, I think. It's quite simple. And maybe for some, it's just antibiotics, fluids, and oxygen, and it's ward level care. And we're being encouraged to think about that with all of our patients. That's a different topic, I know, from ventilator scarcity, but I think it's an important thing. I think we need to all be a little bit sensible about what we're trying to achieve. I don't think we're, I think we're trying to make people's lives meaningful, and it's not just about extending people's life expectancy as long as possible. It's about extending it in meaningful ways, and we need to think sensibly about the right choices for people, because everything has a side effect. Every drug, every treatment has a side effect. People who come into hospital with illness will not leave the same. There will be a little bit chipped away at their life, particularly the older, sicker people. So I think, so that was something I don't know if that's pulling it in a slightly different direction.
No, everything's totally relevant. I mean, especially because, this conversation arose initially because of the way that we're all reassessing the economics of what's happening in care, right? And this is something Zack and I have talked about a lot, right? And that I know he's thought about a lot, right? Is what it costs to do the work that we're doing, right? And so I think on average, when you have these kinds of discussions about ethics, for example, it does veer away from some of those real brass tacks questions about the economics, right? So when you're talking about when to do certain kinds of procedures or what kind of care to provide, what's often left out for the layperson like myself and others are these economic considerations that you all have to deal with in terms of budgets and even the justification of sending someone up for a particular test, right? I mean, there might be a set of protocols that you observe, but as Dave was saying before, right, if you make some kind of different decision, then you're also subject to the problems of liability and litigation as a consequence of those decisions. So you have to be careful yourselves as practitioners about, not electing to have all possible instruments and tests thrown at a person lest you get held accountable for something you missed, right? So I think, Eoghan, what you're saying is totally relevant, because we're all concerned that the costs are just too high, especially in the United States, for the kind of care that's expected by the average citizen.
Yeah, and I suppose that's the challenge, almost the fifth challenge that Zack and you have in the US is that pay for fee or value-based healthcare system piece of understanding there's a cost that's almost directly attributable to the patient. That's not something that actually impinges on our brains when we're doing things. As a resource availability question, there's not a direct cost bit. And if we need to open another pack of something, be it even just an expensive intravenous monitoring line or whatever it is, we'll just open it knowing that, it might cost 500 quid, but actually that's not apparent. And there's lots of studies being done in our population about getting them to think about an understanding of cost. If you pitch up in the emergency department, it costs £150. It's about $350, but that cost doesn't go to the patient. So therefore they will arrive in the emergency department and expect care, not wait for the next day to go to the general practitioner, which is a cheaper model of care. And that kind of perpetuates its way all the way through around about the decision making that we doesn't contribute to what we do is the cost. It's only when you get to governmental level or deciding about drugs that you have to think about quality adjusted life years and how does that how do we spend that resource, which ultimately is a budget, and do we put it towards this drug or that drug? And even within a disease condition, do we make that available? And is that a significant benefit to the population, society at large, to engage, to spend that money? And obviously the kind of biologics, cystic fibrosis drugs are often the ones that we talk about a lot, or chemotherapy drugs that have a high cost and often uncertain benefit. And that remains part of the challenge. But Zack, it must be brutal. You guys have to pay the cost all the time.
Yeah, let's get to that in a second. Can I, before we leave it though, there was something that Eoghan said, and David or Eoghan, if you can speak to this. In the ER, there's a kind of 4-level tier system about ceiling of care. Tell me how that happens. Is it the physician's decision? Is this a patient decision? How does that interplay happen?
It's quite a new thing, Zack, and this isn't an NHS-wide phenomenon. It's beginning to creep in a little bit in our region. I can't comment on the rest of even Scotland, never mind the UK. It's just a local physician has a particular interest, and he's spent a few years exploring this, and you know, he went round and interviewed, I think, hundreds, certainly dozens of consultants in various specialties, and came up with this. It's about good communication. For him, it was about good communication. It was about, you know, being able to relay to, you know, from the emergency room to the ward staff about what is the ceiling of care for this particular patient to avoid any potential harm. Or I mean what this particular doctor had experienced, that, you know, at 3 a.m, when the night staff are looking after the patient, they don't understand what the ceiling of care, the trajectory of the patient is, then they're likely to come in and just try to do everything that they can, when perhaps the feeling of the day staff or the people who looked after the patient was that there should be a limitation to what is provided to the patient. So it's really, I think my understanding of it is it's not concrete set in stone. It's just passing communication about maybe how sick the patient is and what we believe are steps that are perhaps too far, given, you know, we've got to make that decision based on comorbidities, age, frailty, what their wishes are, what the family wishes are, what our gestalt or our gut feeling is about the trajectory of this patient. So it's really just communicating a little bit of information about what way we think they're going and what level of care is probably too much for this patient. But as I say, it's really probably only for the next 24 hours. And it's, you know, to be reviewed on a regular basis, on a daily basis by, I think, then the people who take over that care. And it can be changed depending on the course of the patient. But I don't know if that answers your question.
Okay, well, I think this, because this is going to be germane, I think, to size audience of bioethics, and definitely when we start looking at a UK model versus US model, and it's definitely going to get us into economics here in a second. But I think a critical question here is, who makes that decision? Is it the emergency doc that says, I think their ceiling should be this? Is that how it works in the UK?
Yeah, well, for our hospital, yes. So it's supposedly the most senior person looking after that patient at that time before they are transferred to the ward. So it'll typically
they have the authority to say the ceiling is no intubation.
Yeah, but I should emphasize that it's not set in stone. Like, the ward staff could decide, well, do you know what? I've reviewed the patient, and in fact, I disagree, and so therefore I'm going to change it or do my own thing. It's not a concrete. It's just a passing on of, this was our thoughts. This was what we believed. We've spent time with this patient. You're approaching this patient on the ward. This is what we felt, and this is what we felt was, you know, too much. It's just it's a guide. It's a guide.
I think one of the things that will come up in size class will be asking the question, who deserves that authority? And so when the rubber meets the road, you have a patient that is like, the family's like, no, you're doing everything. And the physician's like, no, we're not doing everything. Who wins that battle?
Yeah, now we're getting into tricky territory. I might let Dave handle this one. But I think basically, I mean, family and patient considerations is a huge factor in the decision. You know, we're not trying to get into big arguments with families. That's not our place in the emergency room. I think we would take patients aside and families aside, and it's more encouraging us to think about it. It's more encouraging us to approach those difficult conversations with family. It's encouraging us to make more sensible decisions about patients, but we would never be making them contradictory to the patient's wishes or the family wishes. Not an emergency. We don't have the time to be getting into heated arguments and debates. But I think it's encouraging us, if we go to speak to the family, that we start to introduce the concept, start to explain that, the trajectory of your family member is not great. And these are the potential outcomes. This is the chance of survival. What were their wishes? What would they like? And it's just encouraging that. And I think if we get to some sort of sensible agreement, then I think we would be happy to document that. But I don't think if there was a strong desire against that the emergency room is the place to be having heated conversations. I think, I should say as well, this is quite a new thing, and it's not essential that a patient has this going to the ward. So if you can't have that conversation, if you can't make that decision, they go to ward without it. And
okay.
Staff.
And then is it a document? Is that what happens?
Yeah. It's I don't know. Do you want me to share it with you? I think I had it on screen actually. Is that worth sharing? No.
Sure. I mean, so in the U.S., we do have something that maybe we're actually talking about kind of a very similar thing. It's called a POLST form, POLST. I'm embarrassed that I probably am going to get the acronym wrong, but I think it's something along the lines of preference of life-sustaining treatments or something like that. And we do them all the time in the ER. I sign these things all the time, which is one of 3 tiers for the top, which is full resuscitation, selective treatment, and comfort care would be the 3 at the top. And then underneath that is a sort of a little bit of a didactic about what exactly that entails. And so a lot of times actually people come in having these things signed by the physician, their primary physicians, and the family and the patient have no idea what they signed. So, I mean, it's like clearly written, comfort care, you will not be intubated. You will not be admitted to the hospital. You're going to get measures that are to treat your pain and suffering. And then they come into the hospital and they're like, wait, what? No. I want to get treatment. I mean, yes, please. So these things I think are, like you already mentioned, a little bit fluid, but they do give us some guidance, and they do allow us, if the conversation was had in the ER, which we frequently do, to withhold those things as they go upstairs. So now this is a relatively uncommon thing, meaning that, like, I'm not talking about the 50-year-old or the 40-year-old these are patients who are in their latter stages of life or have some significant disease already that you say, well, is this what they really would have wanted? And if everyone is sort of in agreement, then we can just start de-escalating care. And in fact, in the ER, we oftentimes have these things already signed before they come in, and therefore we do a lot less for their workup in the emergency room. Is that somewhat similar to what you guys have?
Yeah, so I think there's a couple of points there. So I suppose from an escalation plan in COVID, within that context, we've asked our general practitioners, our family practitioners, to go through their lists in the community and put escalation plans in place for them. So that discussion happens within the context of COVID, but equally in a wider piece. So with pertinent to the AI work, one of the key predictions we use within the COPD platform is mortality and predicted mortality at a year. to drive that conversation. So it's one of our KPIs in terms of making sure people have had the vaccinations. But one of them is about escalation plan and making that, have that in place so that they don't come into the ED, high CO2, not be able to have a conversation, but actually the escalation plan is happen in the cold light of day. So if that person is predicted to have a mortality rate of greater than 50% at a year, then that triggers that conversation for the respiratory physician, so that it's locked in as part of that kind of quality of care, reducing uncertainty when they pitch up in the emergency department. I think it's the same point as Owen's made, but as always, philosophically, what we do is we're the advocate for the patient, and often that is referring them on to other specialties to say, we would like you to consider them for a thing. In the context, I think we're all familiar with somebody with a subarachnoid, significant amount of blood in their head. Is this somebody that should be taken to a neurosurgery? Will there be benefit? Have they got a survivable, operable belief that they should be given a choice or the option of whether or not to do? And often that is a conversation around about trying to demonstrate to somebody down the phone, actually, this person looks pretty good from the end of the bed. They did collapse in the ED. They've got quite a lot of protective, positive factors that makes you think, actually, you should take them. And whether or not you do need to ask for a second, third opinion, which is a context before COVID, but often, certainly within my practice, and it's fascinating that there'll be people that we will put an escalation plan in place that may well be changed, either because they've improved or not further down the line, or that somebody sees them at 2 o'clock in the morning and goes, actually, you know what, I'm going to go with this person hard. But there's a situational awareness component. If I think somebody's going to deteriorate over the next 24 hours, especially towards the latter half of the day, kind of 4 o'clock onwards, I will phone that downstream specialty and say, I think this person's going to cause you problems at 2 o'clock in the morning. Can we just have a conversation now rather than wait for a 2 o'clock in the morning conversation? I think that's an important part of an emergency physician's role. It often means we paint quite a black picture to patients, family, other specialties to say, I think this person's not going to do very well, and they actually do. But equally, I think it's really important that we don't avoid having those difficult conversations. If we think the mortality is greater than 50, 70, whatever percent, even 1 in 20, that is behoven of us to have a conversation to say, there's a risk of deterioration, therefore, what do you want? And equally, for the downstream physicians, what do you want us to do? And actually, when you have that conversation, it's much better to have it 4 o'clock in the afternoon than a fraught phone call when somebody in their bed.
For sure. Yeah, I completely agree with that concept. I do have, I just think a very interesting thing is the physicians, how they paint that picture. And I look at it in myself as well. How do I paint that picture? Is it a fair picture? Is my picture that I'm painting to the family really the right advice? Because I think that sometimes I've been off, like significantly off in the picture that I painted to them. So did I make things, and I'll have to say, in general, I think we miss the mark too far the other way. If you look in total in all of medicine, meaning that not enough people have been described their predicted outcomes and how grim they are. So that overrides. But once you get to the emergency room, and once they're in my care or in our care, the question that I always have is, like, am I being too pessimistic about their care? And this comes up obviously in cardiac arrest, where in the past I would have just said, no, they're dead. I mean, you've been down and you're dead. You've had a cardiac arrest for 30 minutes and I'm sorry. And of course, ECMO and our recent experiences have definitely had a paradigm shift in that way. But then that sort of, I guess, leads into the whole other question about all these other patients. Like, what is the mortality of this patient? And would they really want to be what we call DNR, do not resuscitate? Maybe you guys probably say the same term. Because so often, and I think so many of my colleagues and so much of medicine is encouraging people to be DNR, meaning to make the family or allow the family to choose that this patient should not be intubated, when sometimes that's relevant, or maybe sometimes that's true, and sometimes that's maybe pushing the envelope farther than it should have been.
Yeah. I think we're always affected by the last patient we see, and that anecdote and our perception of would we want for ourselves or others. And if you have some sort of affinity with that patient or that story of would you want that thing done or not done for that individual, be it a family member or yourself. And I think it's being aware of those biases. And obviously, as Pat Crosscarry talks a lot about the biases within emergency medicine, and it's an understanding of those. And I suppose it's that reflexivity to be aware of what's driving you to make that decision. It's just you're brutally hungry and tired, and therefore you probably just need to take a pause and or get somebody else to come into the room to help you with that decision because you just need to sit down, versus did you just have a real epically bad experience the last time this happened, so therefore you're undoubtedly affected by that previous event, and you'll either overcompensate or undercompensate, and very rarely do we get it bang on, which I suppose speaks to Sai's point right at the start of the art versus the science, is a recognition you want to get close, but you're never going to hit the target.
Yeah, and I think.
Sorry,
go ahead, Zach.
No.
Oh, so I think the even like third factor, and I'll move fifth factor. I don't even know where we're at in factor numbers, but then you start getting this external input about, oh, we don't have enough ventilators, or, oh no, we're limited on BiPAP machines. Oh no, we're, COVID patients shouldn't be intubated early. Oh no, wait, COVID patients should be intubated early. And so you've got all these like external things that are pressuring you, and it's so hard for us as humans to make calculations on aggregate data anyway. Like, what is the risk of me dying in a car accident? What is the risk of me going on a ski trip with Sai? It's difficult to assess that risk even in general population. And then when you put all this imperfect stuff on top of you, there is a likely chance that you are making significantly wrong decisions as far as the potential or your ability to have that resource and the potential predicted mortality for that patient in front of you.
Yeah, and now even when you think about positive predictive value and the proportion of those patients that are going to be affected, have a positive and negative test, when you apply that to a population group versus an individual, and that's the challenge of sensitivity versus predictive values. And ultimately, this is into Bayes' decision making. And how do you think, as a clinician, are you a scientist? Do you work in pretest probabilities, or is it much more Gestalt, shoot from the hip? I think, therefore, either with a confluence of evidence and understanding and keep reading, or they just look pretty sick. What do I do? Do I need help? Do I not need help? Do I hit a big red button and throw everything at them? Or do I do a bit more information gathering and then have a value-based discussion with family, the patient, about what's best? And clearly the 16-year-old that comes in that's been hit by a car, you hit the big red button and throw everything at them, versus that's a sliding scale of how quickly do you have to intervene and do things based upon acuity and premorbid state? Probably.
That's great. Thank you.
Okay, so economics, should we dive into that a little bit, Sai?
How are we doing on time, Dave and Eoghan?
You're
might have to go soon, but I'm okay for a wee bit longer. Yeah.
Yeah, and thanks again
we've
for
probably not much to say on this. I've never, ever thought about economics for anything I've ever done for any patient in my life. I've never, ever, it's never factored into my life ever. And that's probably the beauty of working in the NHS. Perhaps David at a more managerial role may consider those things, but it's never factored into my life. If a patient needs something, they get it, and I never think about the cost. And that's the beauty of the NHS, Someone will have to think about it, but not me or the patient. But Zach, you'll obviously have a lot different.
Well, no, actually, what's so fascinating about this discussion is that my gestalt, if you want to use that word, is that it's the opposite. That I feel like I don't think about the economics of it very much. and that I feel like in England, the few experiences I've been over there, is that it does seem, and I think that we unhealthy, that's not a word, but that it's not healthy how we disregard economics in the US for healthcare. And that there does seem to be more teaching in the UK about how to incorporate the economic decision making involved in everything. I mean, I heard a lot of disgruntled physicians at one of the UK conferences about the limitations of resources and how the NHS is not allowing me to do this and not allowing me to do this. And in some ways, I'm like, yeah, but that's probably a good decision. Like, that's probably a decision we should be doing in the US, because we aren't limiting this resource and it's not terribly efficacious, and yet we still do it. So I actually, maybe, and I'm highly biased in this regard. So if you see it when I talk, an economic bias towards what we do, I don't feel it. I feel like in the US, we just do everything and we think about consequences of cost, not enough, because like David already said, it does have real consequences to patients. Like, they do end up paying for some of this. There's a lot of times when they don't end up paying for it, but some people are drastically affected by the cost of healthcare, and yet the clinicians don't think about it as much as they should.
Yeah, I mean, Ty, this is multiple podcasts and PhDs and God knows what else to get to the bottom of this. But I think it's fascinating, Zack, and I think that is the US problem, is that there isn't a thought about cost. You just do it. And I suppose it's also the context of an emergency department. You provide that care, or the patients come up and made a decision that they're going to come there versus not, and they'll come in a blue light ambulance, you do some stuff, and the restrictions happen later. If you find the cancer when you CT them, it's the oncologist that has a conversation about the cost of cancer care, not that you've done a CT for their trauma presentation. So I wonder if within the ED, it's not as apparent as downstream, where there are drivers and time to make decisions about often costly, lengthy treatments that have both an impact on quality of life for two reasons. One is your outcome, but equally the crippling cost of saying, yes, I will have that operation, or no, I won't. Whereas our decision making, even if you take it as simple as varicose veins, it's all done on quality of life, justification of whether or not that it's a procedure that should be considered. But then there's patient preference, physician preference that interplays over that. But for it to be an available operation, for it to be thought of as an option, has to justify both, as the IHI says, clinical outcome, a patient outcome, an economic piece, and clinicians to be engaged in adhering to it. And I think that's, do we think about costs? No, when they're delivering care. Does it impact our ability to deliver care? Yes, because we don't have unfettered access, because the driver is not to make money. The NHS is not for profit.
Yeah, I should have emphasized, yes, that there's probably economic restrictions at the next pay grade up to me, in that we may have a certain limit on what is available to us as emergency physicians in what we can do, what resources are available. But in terms of those resources that we have, I've never thought about the economic impact of what's available to me. But yes, I'm sure the NHS, we won't have limitless possibilities like you guys might in terms of what we can and can't do, but that's for others to think about. At my level, I've never really thought about the economic stuff, but I'm sure it has impacted us, I'm sure.
But I suppose the argument, Owen, and this now turns into a UK piece, apologies, Si, is that we have to, because ultimately it's about resource scarcity. We have a limited budget, we have a limited ability, we have a limited number of beds. If we admit everybody with chest pain, because 1 in 100, if you think about negative predictive value for a high sensitivity rodent, it's 99.4, so you will have an adverse outcome. But we don't admit everybody, we go with that because of ultimately a clinical and an economic justification that doing a high sensitivity test, it costs more money rather than doing amylase and a AST is of benefit because it reduces bed days and is an acceptable error rate in that test to apply it. Whereas Zack, if somebody comes in chest pain, will get a triple scan for dissection, coronary artery disease and PE, and probably admitted overnight for observation just to prove that the syncopal event wasn't driven by something else. Because he can charge back for us. We've made as a NHS at an organisational level, at a clinical operational level, a decision that we will apply a decision-making rule about chest pain using a high sensitivity troponin that allows us to safely discharge the vast majority with an overlay of break glass clinical stop that says, actually, I don't believe that troponin test, I'm going to omit them or do a CTA because I think they might be a dissection. So we do make a decision, but it's not apparent because the protocols are written with a scientific justification that includes the economic argument for whether or not that test is available or not.
Yeah, that was what I was trying to say, but just more eloquently. Like someone else has made the economic decision for me, and I'm just doing it without thinking of the economics. Someone else is doing it. But
yeah, the chest pain one is really good analogy. You know, as you get older in the U.S., there's Medicare, which is essentially is much more similar to what you all have with socialized care. When you're younger, and this is where I see these, maybe the rubber hits the road, is that the younger patient with abdominal pain that gets a CT scan. So, you know, like the chance of them having something in a lot of these cases is probably pretty low. It's not zero. Who knows what the actual number is? But the cost of that CT scan to the patient is several $1,000s. So that's money that I think people don't understand when they come to the emergency room, that CT scan that we just decided on is a lot of money. And our ability to say whether you do or do not have appendicitis is made by that CT scan. But if you're preclinical, or if your clinical thought on this is low, then maybe people would choose to do a CT scan less often.
Yeah, and that's ultimately, I suppose, where we get to with things is that interplay now that we will preferentially scan to be able to discharge. Because actually the cost saving is such that we throw front end money at scanning them early, then we reduce their length of stay. So CT renal colic being the perfect example of that somebody comes in with flank pain, you're kind of vaguely ruling out AAA, but actually what you're doing is allowing you to say, this person doesn't have perinephritic stranding, they don't have obstruction, therefore they don't have a kidney stone that's significant, I'm going to be able to send them home and not park them in a bed for 24, 40 hours. And a lot of, I suppose, the prediction work that we do is around about prediction of length of stay, because that has a direct cost. It's very visceral when you've got a hospital that's entirely full and ambulances parked outside because there's no flow in the hospital, which is a daily occurrence in both of our hospitals, and I'm sure. And therefore, how do we turn the dial on that? And ultimately, prediction of both safety, i.e. admit discharge, and then length of stay as a driver of how can we identify elements in that care pathway that we can throw a front-end investigation, test or therapy at that reduces length of stay, which ultimately is a bigger cost. And equally, that cost shouldn't be underplayed. It's a cost to that individual patient, but also to the other patients parked in the ED, for which we know bed blocking increases mortality. So there is a piece around about resource allocation, thinking about the next person, but knowing that somebody in an ambulance queue of unknown severity of illness is at greater risk than the person that's actually been seen and has their illness investigated and codified.
Differences in medicine management throughout is just, it's such a fascinating thing.
Zach, I was going to ask, do you guys discuss the costs with your patients before doing tests, or do you just do them and bill later, or do you actually make decisions based on what the patient can afford, or just curious?
No, well, I would say that it sometimes kind of takes you back a little bit when someone says, No, I don't want to do that. It's too expensive. So that's pretty. It's relatively rare that somebody says that. But I actually think it would be more healthy if we did have that discussion more often. And maybe that sounds bad to you, but I like David already said, you guys are doing that. You're having that decision. Some smart people in a room looked at the data and said, yeah, and you know what? We shouldn't be scanning these people. And you know what? We shouldn't be admitting these chest painters. Whereas I think there's maybe a much more on to the given physician. It also goes back to David's cohort versus individual patient analysis on whether you're going to apply that cohort data to the individual patient in front of you or not. And maybe in the US, we're left with a little bit more with the physician deciding on whether they think that patient fits into the cohort. Whereas in England, they are saying, well, as an aggregate and as a single payer, we know that this is a better strategy overall. And I think that there's significant advantages to how you all do it versus how we do it. Let's see, I think that's it for that.
I suppose a classic example, Lowe and Zack, of that is lung nodules on CT, that we've moved the threshold up again and again from 3 millimeters now, I think, to 5, and I'd have to check. It's not obviously my area of specialty, but because we're doing a CT coronary angio trial, but generally in Scotland, we moved that threshold of who needs a further CT for follow-up. It was every day 3 millimeters needed it, and then we've gone, actually, wait a minute, we're just scanning a whole lot of people that don't have any benefit, giving them more radiation and a cost, and moving that with evidence to 5 millimeters and maybe beyond that now, saying, actually, if the nodule's less than that, then let's leave it alone. Let's not over-investigate, recognizing there will be some people who will have cancer later on and the nodule will grow, but accepting that we shouldn't do that. Whereas I can imagine anybody that vaguely the evidence of any sort of nodule on CT gets multiple investigations and a biopsy if they possibly can shove a needle into, because that it's available and therefore it reduces risk and can be built against.
I'm less familiar. I can't really speak to that because I don't know the outpatient management as well. I did, though, going back to one of the things you had said before, I think is very interesting about looking at like where is the sweet spot between just observing someone versus doing the scan and sending them home, like your renal colic example. I would be fascinated. We would have to get like a whole, list of data of patients per day and look at how the management actually plays out in your system versus our system. But I think we've actually moved away from most observation patients. So even like non-specific neurologic things, I get an MRI like as fast as I get a chest X-ray. So it's like if they have a non-specific neuro thing, or they have like a TIA, not true TIA, but maybe some semblance of a TIA, we get the MRI, we get the MRA, and we send them home. So I do think that
keeping them in hospital, because we've done the same, that we used to observe head injuries, because I know one's a wee bit older than me, so I can say this slightly cheekily to him. I can just remember the days that you would park somebody in a bed with a head injury because you couldn't get a scan overnight. Whereas now, somebody's bumped their head, we're overly liberal. We don't do biomarkers. We just say, bumped your head, you've got some symptoms, there's some degree of worry. I'm not even going to apply a decision-making rule because I'm not going to observe you, I'm not going to admit you, but I can scan you within 20 minutes, get a result and send you home. So therefore our rates have gone exponentially through the roof for minor head injury. But it's driven by the economics, ultimately, of saying scan is cheaper than an admission. Admission costs 1,500 quid, scan costs £250. Therefore, let's do a scan and send them home within 4 hours.
Yeah. Which I actually think that's pretty good medicine. I mean, I think that
except for the rate of cancer, if you think about it. So a CTPA, if you take that example, is 1 in 2,000 risk of cancer if you scan a sub 30-year-old woman. That's not an insignificant. That means you and I both will have given somebody cancer by the end of our careers. And but it's not a direct risk to that individual patient. They've come in worried about chest pain. Even if you have that conversation with them, they'll say, scan me, because 1 in 2,000 versus the 1 in X, which is lower risk of PE and a bad outcome from that. I'll take the scan and worry about cancer risk in 20 years' time.
Yeah, I think I should probably take back what I said as far as good medicine with over scanning of head injuries. I think actually, so I'm just sort of thinking back to how we do it here. We use a lot of just for head injury and C-spine stuff, like those are pretty straightforward algorithms. I think most of us use them to
it's
decide
whether not to get a scan out of those. If you think about C-spine, if you take the Nexus and Canadian rules, you have to work quite hard to not scan somebody. Essentially, anybody over 65 who's had a car accident, it's not been a rear-ended shunt, gets a scan.
Yeah, so if they're over 65, I mean, if you apply Canadian rules, then, and the Nexus was critiqued for not really doing well in the older people, which I don't think is really that true. But there's a time, because most car accidents is the young person who's got whiplash, right?
Yeah.
And so you just push on their neck. They're not drunk. They can move their hands. No paresthesias. Bye-bye. So I think that's a big savings for us as CT scans. But again, no one is required to provide or to do that. But I think that to me is a reasonable level of care where if you apply a basic rule, and if they fall out of the rule, you scan them quickly and you discharge them. I think that's a reasonable way to practice.
Agreed, depending on the performance of the rule.
Yeah, agreed. Sorry, Sai, we kind of took over a little bit. What do you want us to go any place?
No, that's great. The conversation's fantastic. Thank you.